Hello, my name is Ariana Vera. I am going to talk about pharmacology and the treatment and complicated skin and skin structure infections. Definitions. The structure of the skin is made of three main layers: epidermis, dermis, and subcutaneous tissue, each of the which is made of several sublayers. Skin infections can occur frequently when there is a break, cut, or wound in the skin. It can also happen when our immune system is weakened due to another illness or medical treatment. Cases. Infections of the skin and skin structure are estimated to cause more than 15 million infections and 817,000 hospital admissions annually in the United States. Rates of these infections are substantially higher than 10 to 12 years ago, due in part to the emergence of methicillin-resistant Staphylococcus aureus in the community.
Hello everyone. My name is Dr. Diwan and the topic of the lecture today is skin and soft tissue infections. In this lecture, we're going to talk about skin and soft tissues being infected by different kind of organisms. We're going to talk about different kind of manifestation does it present with. It can be vesicles, it can be pouches, it can be bullas, it can be custard lesions, or it can be many other pathologies that we'll look for. So first of all, we're going to talk about the anatomical relationships of the skin so that we might know the placement of every structure so that when we talk about their pathology, we know that where that structure is present and what's around that structure and what structure gets affected next. Next on, we're going to talk about all the infections which are associated with the formation of vesicles. We're going to talk about infections which are associated with bulla formation. We're going to talk about what bulla is and in which infections does it manifest or does it form. Next on, we're going to talk about infection associated with custard lesions. We're going to talk about what custard lesions are and how these are associated with different kind of infections. Next on, we're going to talk about folliculitis, what folliculitis is. And among the folliculitis, we're going to talk about furunculosis, we're going to talk about hot tube folliculitis, we're going to talk about what swimmer's itch is, how does it present, and we're going to talk about acne vulgaris and how it is associated to a skin infection. Next on, we're going to talk about myositis and myonecrosis, which means inflammation of the muscle and degradation of the muscle. We're going to talk about what organisms causes pathology and how does it manifest. Next on, we're going to talk about necrotizing fasciitis, which is a rather emergency of some kind, which organisms cause this necrotizing fasciitis and how does it manifest. Next on, we're going to talk about ulcers with or without eschers, which ulcers are there, in which pathology is found. Next on, we're going to talk about erysipelas, which is called by Streptococcus pyogenes, how it is differentiated from cellulitis. We're going to talk about what cellulitis is. We're going to talk about how does it manifest, what organisms are responsible, and how it is treated afterwards. Next on, we're going to talk about papular and nodular lesions. We're going to talk about each one of them, that what organisms cause them. Next on, after getting all of this data on different kind of skin and soft tissue infections, we're going to go for the diagnosis. First of all, we'll talk about the history. In the history, we'll talk about specific factors which will help us in reaching our differential diagnosis. And from there, we'll go for the different diagnostic modalities. We'll go for the soft tissue radiography if it's required. We'll go for the pinch biopsy if it's required. We'll go for the tissue sampling if it's required. And then in diagnosing that patient, we can also go for open surgical inspection and debridement of that patient. And that might also help us in reaching the diagnosis. And once we have reached the diagnosis, we'll go for the treatment options. We'll go for the treatment modalities. For different infections, the different modalities are there. For example, if it's herpes simplex, it's going to be a cyclovir. And we're going to talk about each and every one of them infections and their treatment.
Applications in medicine. Its applications in medicine are to combat gram-positive bacteria. It also has an effect against methicillin-resistant Aureus coagulase-negative Staphylococcus, Streptococcus, and Enterococcus, improving activity against some strains that are not sensitive to vancomycin and reduce the frequency of resistant mutants. Studies. The use of the two antibiotics dalbavancin and oritavancin for the management of infections of the skin and skin structure has recently been studied. These agents alone patented with complicated skin and skin structure infections, which might otherwise require hospitalizations to be treated on an outpatient basis without compromising efficacy and without the need for laboratory monitoring on in the following intravenous catheter. Pros and cons. Pros. Terminal half-life for both are approximately 2 weeks, and serum-free drug concentrations exceed mixed for a week or more. The treatment was designed to take advantage of this property by means of the administrations of one or two large, whose dozen instead of smaller closely spaced. Either again it's easier to administer, reducing or in some cases eliminate costs and risks of hospitalizations. They have concentrations definite killing, vancomycin like safety. Cons. Minimum inhibitory concentrations mix are higher than for soft-lived strains. Dalbavancin is an activity against van strain of vancomycin-resistant S. aureus (VRS) and vancomycin-resistant Enterococcus (VRE). Neither antibiotic is more efficacious than vancomycin. The efficacy of these antibiotics for infections other than complicated acute bacterial skin, this drug tend with to clear and moderate of severe toxics or allergic reactions. If they occur, could cause substantial morbidity or probable fatal. Issued applied in Ecuador. The antimicrobial resistance that bacteria are acquiring is today a serious problem due to the indiscriminate use of the antibiotics and hospital infections. For this reason, need antibiotics are tested every day to combat MRSA, among which are dalbavancin. In complicated cellulite is initial treatment is surgical drainage, antibiotic therapy based on clindamycin or vancomycin, plus adjuvant therapy that included elevations of the affected limb, analgesic and tetanus vaccine if it were due to human or animal feed. Treatment. Purulent cellulite with purulent drainage or exudate in the advancement of a drainable abscess, whose causative is community-acquired methicillin-resistant Staphylococcus aureus, clindamycin, trimethoprim, sulfametosol, doxycycline, minoxidil, or lisinoxide should be administered.
Hi, this is Tom from ZeroToFinals.com. In this video, I'm going to be going through skin and soft tissue infections. And you can find written notes on this topic at ZeroToFinals.com/cellulitis or in the infectious diseases section of the Zero to Finals medicine book. Let's jump straight in. Cellulitis is an infection of the skin and the soft tissues underneath. Skin is normally a very effective physical barrier between the environment and the soft tissues underneath. When a patient presents with cellulitis, look for a breach in the skin barrier and a point of entry for bacteria. This may be due to skin trauma, eczema, fungal nail infections, or skin ulcers. How do patients present? Well, the skin will demonstrate changes of cellulitis and soft tissue infection. And these key changes are erythema, or red discoloration of the skin. The skin can be warm or hot to touch. It can be more tense and thickened. It can be edematous, with fluid collecting on the skin. And when fluid-filled blisters develop, these are called bullae. And a characteristic golden yellow crust can be present and indicate something called Staphylococcus aureus infection. Remember that Staph aureus causes this golden yellow crust. Impetigo is where you get a skin infection around the mouth or around the chin, and this has that characteristic golden crust caused by a Staphylococcus infection. So that brings us on to the causes. The common causes of skin infections are Staphylococcus aureus, and this is probably the one to remember as it comes up the most frequently. Group A Streptococcus, mainly Streptococcus pyogenes. Group C Streptococcus, mainly Streptococcus dysgalactiae. And MRSA is another key cause that needs to be considered, particularly in patients who are long-term residents in nursing homes or spend a lot of time in hospital. There's something called the ERON classification, which you should be aware of, as this is the classification system which NICE recommends for assessing the severity of cellulitis. Class 1 is where there's no systemic toxicity or any comorbidities. Class 2 is where there's systemic toxicity, so they're systemically unwell, or the patient has some sort of comorbidities. Class 3 is where there's significant systemic toxicity or significant comorbidities, which put the patient at risk of deteriorating quite significantly. And Group 4 is where there's sepsis or life-threatening infection. NICE recommend that you admit patients for intravenous antibiotics if they fall into Class 3 or Class 4, and also admit any frail, very young, or immunocompromised patients. So if there's any significant comorbidity or significant systemic toxicity, or of course sepsis, then they should be admitted for IV antibiotics. Which brings us on to the choice of antibiotics. Flucloxacillin is the one to remember, and it's very effective against Staph aureus infections, and it also works well against other gram-positive cocci. It's usually the first choice in treating cellulitis, particularly if they're being treated in the community and it's fairly simple cellulitis, but flucloxacillin can be given orally or intravenously. Alternatives to flucloxacillin are things like clarithromycin, which is a macrolide and can be used in penicillin allergy. Clindamycin is also very effective and has quite a broad spectrum of antibiotic coverage. And coamoxiclav can also be used and has a broader spectrum of bacterial coverage. But remember, it's penicillin based, so it can't be used in patients with penicillin allergy.
Conclusions. Antibiotics are not vitamins and are not given for any flu or injury that excited. A poor antibiotic prescription may cure an infection slightly, but it will cause greater resistance and be worse in the long run. The initiation of an adequate treatment and timely antibiotic monotherapy has demonstrated its effectiveness. in the treatment of skin and soft tissue infections in most of the shield populations. Future clinical trials are needed to define that safety and efficacy profile, especially in skin pathogens and for more serious infections in which the need and grade to improve management and reduce costs. Thank you.